How are the things going on?
Yeah, going on well. Yeah, Gujaram, Vinayak, we can start or what? Vinay,
Please wait for my signal.
yeah.
We are live now. Dr. Jairam, you can start.
Okay. So, good evening, everyone. I am Dr. Jairam Navde. I am working as a consultant in the critical care medicine at SL Raheja Hospital, Mahim, Mumbai. And I am the chairperson of the ISPEN Mumbai branch. I welcome you all to today's 8th webinar of the ISPEN Mumbai branch on the topic, very important topic, feeding intolerance in the ICU. Thank you, Sanjit sir and ISPEN for allowing the ISPEN Mumbai branch to conduct this webinar without any charges. So, for today's webinar, we are going to invite the dietitian Padmaja Padmaja Joshi madam. Uh, so, uh, she is the chief dietitian, registered dietitian, and clinical nutritionist in the field of nutrition. She has a very wild experience of 36 years in the clinical nutrition. She is also ex-chief dietitian at the Koitam Hospital, Indore. She is a life member of many branches of ISPEN, IPEN, and IDA. She is a founder secretary of ISPEN Indore chapter. She is a executive committee member of ISPEN Mumbai chapter, and she is a founder president of IDA Indore chapter. She has many publications, and she has many presentations. Especially, she has special interest on the topic of burn, and she has got awards like A.N. Radha Practicing Dietitian Award in 1999 and K.J. Naidu Medical Trust Award. So, this webinar will be very important and very interesting. So, kindly attend this webinar till the end so that we can have a very fruitful discussion. And if you have any queries, kindly ask in the chat box. Over to you, Padmaja madam.
A very good evening to everybody. On the behalf of ISPEN Mumbai chapter, we are going to conduct a webinar on feeding intolerances in the critical ill patient. Friends, as we all know that this is a very common problem faced by us dietitians and doctors in the ICU on day-to-day basis, and actually it needs to be dealt in a very systematic way to achieve that feeding goal, full strength feeding goal, and ultimately a faster recovery and to reduce the stay in the ICU. Okay, so for this session, friends, we have highly experienced and experts, speakers and panelists with us. Our speaker is Dr. Swapnil Khadke sir. He is HOD intensivist and HOD intensivist physician, critical care medicine department, Fortis. I'm sorry. Dr. Yogesh sir, he is the expert speaker with us. He is currently working as a professor and ICU in charge in the Department of Medicine, IIMSR, Secretary ISCCM, and Secretary ISPEN, 15 years of experience in the critical care medicine, ex-assistant professor, UG teacher, PG guide, MMC accredited speaker, key role in organizing many conferences and workshops in the region, many publications in the field of critical care to his credit. His special interests include electrolyte imbalance, ventilatory strategies, ARDS, sepsis, septic shock, ICU nutrition, neurocritical care, critical care, endocrinology, and cardiac arrhythmias, and many more. Along with this, we have experts, panelists with us, which includes Dr. Swapnil Khadke as an HOD intensivist physician, critical care medicine department, Fortis Hiranandani Hospital, Vashi, Navi Mumbai. He is the head of the department and intensivist physician in critical care medicine at Fortis Hiranandani Hospital, Vashi, Navi Mumbai. Treasurer of ISPEN Mumbai branch, holds MBBS, MD, ID, CCM, FCCCM, CCD diabetes degrees, co-author of the clinical approaches to basic and cardiac intensive care, executive committee member of IMA Ulve Navi Mumbai. Welcome, Dr. Swapnil Khadke, sir. And last but not the least, our dynamic sir, Dr. Sanjit sir, as a director critical care at SL Reja Hospital, President ISPEN, and currently he has been recognized as one of the expert from Asia to share his insights and experts in the topic highlight acute care. Congratulations, sir. Welcome all the speakers and panelists on the board. We are looking forward for a great interactive session, which is very close to, I think, all the dietitians and doctors' day-to-day work. Yes, sir.
Shall I?
Yes,
Yeah.
Dr.
Yeah,
Yogesh,
sure.
sir.
Yeah.
Yeah. Please start with your session, sir.
The screen is visible.
Yeah, it's visible, sir.
Thank you very much, ISPEN Mumbai branch, Dr. Jairam, and our dynamic national president, uh, Dr. Sanjit, who has been arranging webinars uh, throughout the year, and lot many in the critical care field and in the nutrition they have been arranged, and they have been arranged till now, and this is the eighth webinar on which like we'll be going with the feeding intolerance. We'll be discussing with that, and in the critical field, like when the outcome of the patient matters, uh, in the ICU, that when to start enteral nutrition. The SPEN guidelines or SPEN guidelines are our practices. We are starting the enteral nutrition as early as within the 24 to 48 hours. That has been found to improve the outcome of the patients, and early starting that is one of the important aspect for outcome of the critically ill patients, along with the other therapeutics that we are using. ICU patients, when the GI tract is intact and expected to tolerate the enteral feed, you have to go with the enteral feed. Begin the enteral feeding within the 24 to 48 hours. Identify specialized formulation if needed, but they may not be added at very early stage. And different critically ill patients like septic shock, then the immunomodulators, they have been found to be effective in the surgery, trauma, or burn patients especially. uh, they have been found, but if your patient is not stable, then you will have to go for the resuscitation, and then only you can consider for the starting with the enteral feed or low feed. That is our routine approach that we all have been following, uh, following in our ICUs. uh, and important aspects of ICU nutrition, for as I told you, that regarding the outcome of the patients. Now we have like indirect calorimetry to chart out the requirement of the calories. That has been gold standard in the ICU. Then that is equally important, that there has to be no overfeeding also, and as underfeeding or malnutrition, that can have the bad outcome for the patient. Then equally like overfeeding, it can have the bad outcome for the patient. And even protein, like you have to chart it properly. Then with body impedance analysis, you can calculate the absolute lean body mass, and you can calculate the protein requirement for the patient. These are the current practices we are following. But as we start with the enteral nutrition for the good outcome of the patients, we can like today's topic, like feeding intolerance. The feed may not be tolerated, and we may have to change our strategies, or we may have to go with the alternate thing. Even like we can go with the parental nutrition. Like what are the symptoms when we suspect, or when we label that patient is having feeding intolerance? Omitting, classically it will be there. Then lethargy, apnea. Then signs, abdominal distension, visible abdominal distension we can see there. Increase gastric residuals, 2 ml per kg. This is variable throughout the trials, or throughout the literature. This has been variable. Abdominal tenderness, that can be there. Reduced and absent bowel sounds. That's why the clinical examination that matters. When only you go for the gastric residual volume alone, or along with the clinical presentation and clinical signs, they are very important. Definitions: in the 2012 ESICM working group on abdominal problems proposed for the first time that feeding intolerance is present if at least 20 kilocalorie per kg per day via enteral route cannot be reached within 72 hours. There was fallacies in this definition. Like the over 3 days period was considered, and that was the main that consensus could not be there on this definition. Then came the gastric residual volume potentially with objectivity. We had to have the objective markers and quantifications. This was once preferred widely as one of the gastrointestinal symptoms to define feeding intolerance with or without other gastrointestinal symptoms. But again, the study shows concern about the reliability of the gastric residual volume monitoring, because in different ICUs or different region, the volume that has been considered, it is like taking right from 200 ml to 500 ml. So, but still, almost all the ICUs, this is one of the thing that we are following, and that reliably, along with the clinical symptoms and signs, can give you or you can go with the diagnosis of the feeding intolerance, and you can formulate the different strategies for that patient. GI complications to observe, again the same things like abdominal distension, then high, as I already told you, gastric residual volume. That usually we can monitor for 500 if it is nowadays it is considered 500 ml when it is monitored 6 hourly, and if you get that, definitely at that time you may be stopping your uh, feed in that patient. Again, the omitting diet regurgitation with the enteral formula. The diet regurgitation you can see in the mouth on the clinical examination itself. Then diarrhea, 5 or more liquid stools in the 24 hours, that can be there. Even constipation, like you are going on feeding and feeding, and the patient is not passing the motion. That's why daily examination and daily inquiry regarding all these important parameters is very important when you have to have the good outcome for the uh, critically ill patient. This is one of the important slide I will like to highlight. These are the many. This is one of the good study that was carried on. Many factors were considered, and those were seen which were responsible for the feeding intolerance. As we can see that age more than 60 years old, then hypokalemia, then starting the enteral nutrition more than 72 hours, then no dietary fiber in the nutrition, then intra-abdominal pressure more than 15 mmHg, then central venous pressure more than 10 centimeter of water. You can see there they are highly significant factor. The p value is less than 0.001, and other factors are also there which are significant. The p value is a bit more, like Apache score, then hyperglycemia, then mechanical ventilation, then use of sedatives, then use of vasoactive drugs. already we have seen that the main concern comes for the feeding when our patient is on the mechanical ventilation, and many of the times when we are formulating the sedation strategies, that also in that condition also, like it matters, like feeding intolerance can be there. Our patient is completely supine. We may That's why, like we have to keep our patient like 30 to 45 degree inclined. That preventive measures we can do. Then vasoactive drugs, already we have discussed that when our patient is unstable, many of the times we may not go for the enteral nutrition, or we may go with the low volume of the enteral nutrition. So these all the factors, these are very much important, and those are very important for the outcome of the patient, or for starting enteral, or for successful enteral nutrition. Mechanism, the proximal stomach, when a patient is critically ill, that prolonged fundal relaxation, that can lead to the increased gastric residual volume. There are reduced fundic contraction, that can be there. There is a lack of fundo-enteral motor integration, uh, as well as many of the enteral hormones, like enterogastric feedback hormones, they have been found to be increased in the uh, when gastric feeding intolerance is there, and basically there is no coordination there of that peristaltic movements, and that fundo-enteral motor integration is not there, and that leads to that increased gastric residual volume, and that leads to feeding intolerance in these patients. And many of the underlying factors, like there can be severe sepsis, hypokalemia can be there. All these, like collectively underlying factors, you have to address when you are seeing, and whatever clinical presentation you are going to see, you will have to tackle the underlying problem when you suspect that. Then along with those factors we have seen, clinically we can see this is one of the important aspect in case of the feeding intolerance, or when we see that causes of the intra-abdominal hypertension or abdominal compartment syndrome. I will just take this part as a manifestation of the underlying various etiologies that we are facing in the ICUs, like diminished abdominal wall compliance can be there. Most commonly, like we'll be facing problem of the feeding intolerance post abdominal surgeries, and the component will be the less compliance in abdominal surgeries. Intra-abdominal adhesions, this is again one of the important factor to develop the uh, intracutaneous fistulas. Major trauma can be there for reduced abdominal wall compliance. Increase intraluminal volume, like we can see that gastroparesis is there, because it can be because of hypokalemia. Gastric distension, we can observe clinically, that paralytic ileus, that is the most important cause, most common cause we face because of hypokalemia in the critically ill patient. That can lead to that ileus. Even constipation can be part and parcel of that. Then increased extraluminal abdominal volume, uh, hemoperitoneum, then pneumoperitoneum, severe pancreatitis, liver failure with ascites. Day-to-day practice, we are seeing all these patients. Then retroperitoneal or intra-abdominal tumors, intra-abdominal abscesses. Then here comes the importance of the monitoring of intra-abdominal pressure, that can be easily monitored nowadays, or from the clinical history, clinical examination itself, like you can consider an underlying etiology also you have to treat, that can lead to feeding intolerance most commonly in all these patients. Then there can be overzealous fluid resuscitation, that can lead to abdominal compartment syndrome, or increased abdominal hypertension, that can lead to feeding intolerance. Treatment, the underlying conditions you will have to treat in this case particularly, like for the intraluminal volume, you can have the nasogastric decompression, like in the intestinal obstruction, we are following with that rectal tube decompression. Percutaneous drainage can reduce the extraluminal volume in case of ascites or hematoma. Abdominal wall compliance can be improved with adequate sedation and neuromuscular blockade when the patient is on mechanical ventilation. Then removal of the constrictive dressings, that has leading to the decreased abdominal wall compliance. optimizing fluid resuscitation as a part of fluid management, as a part of that is very important thing that you have to follow in your critically ill patients, and goal directed resuscitation only has to be there for the better outcome of your patient. This is one of the again specific reason, or when we encounter this problem, like we may not go for the enteral nutrition in this case, but mainly in the high output intracutaneous fistulas. uh, many underlying etiologies or abdominal problems they encounter, or they can lead to this pathological situation like trauma, and many of the like extensive adhenolysis. When a surgeon is operating, when the adhesions are there a lot of, and patient presents with the intestinal obstruction, and then that patient lands into the intracutaneous fistula. It can be a high output intracutaneous fistula where the output of the fistula is more than 500 ml per 24 hours. But one thing I can I would like to tell here, clear advantage for TPN within the fistula healing is not agreed upon currently. Like even if intracutaneous fistula is there, you have to go with the enteral feeding. That can be very well tolerated. Only other strategies that to close that intracutaneous fistula that you will be opting, like somatostatin and agonist like octreotide that promotes earlier closure of the fistula, that along with the enteral feeding you may have to go, or you will be adding the parenteral nutrition as a part, or you can combine both the partially both the nutrition in particularly in this condition. Then
Yes.
lactose intolerance, we can see that many of the patients they are intolerant to lactose. Then milk and milk products you will be avoiding for feeding such patients, that you will have to suspect, or such history may be present previously in those patients you may get. That will be the thing, that will be the clinical judgment of the clinician or intensivist. Then regarding the management of the feeding intolerance, the underlying etiology that you are managing, that will be the very important thing. And when like you are so sure with the diagnosis of the feeding intolerance in this patient, like where vomiting is there, abdominal distension is there, pain is there, the perform physical examination, see the bowel sounds, that is very important. That's why clinical examination matters a lot, rather than any investigations. It matters over all those investigations. Feeding should only be stopped abruptly for those patients who demonstrate overt regurgitation or gastric residual volume, like you are monitoring or you are following with, that can be more than 500. Many of the prokinetics like metoclopramide and domperidone agents for gastric motility improvement, they can be started even prophylactically. Some of the studies have shown that they have been started prophylactically, or even that they can be as soon as you diagnose feeding intolerance, you can start with that. They have given the good result. But tachyphylaxis is the problem with all these agents. Their effect can win over like next 2 3 days, and that's there comes the combination of the metoclopramide and erythromycin. But again, the combination there can have the cardiovascular side effects, like they can happen with torsade D pointers or something like that. You have to monitor all these things, because already the critically ill patients are already on the various polytherapies. Then continuous enteral feeding versus intermittent enteral feeding. The difference has not been given on the clinical trials or in the studies. Both are at the same, but if you have you can go for that, like you can go post pyloric if really gastric intolerance is severe there. You can put post pyloric nasogastric tubes, or you can go even go for the jejunostomy for such patients. But that will be the latter option for tackling the feeding intolerance. Oligomeric formula, when like peptide based formula, they can be helpful in tackling the feeding intolerance. Then post pyloric feeding, that already we talked about, jejunal tube placement. Continuous enteral feeding may be tried for. Sorry. This is like metoclopramide versus this figure will show you that the A graph, in the graph A lines, that is showing the metoclopramide effect. Then B is erythromycin 200 mg BID. and C is the metoclopramide and erythromycin combined. It has been shown that over the 7 days, the like metoclopramide plus erythromycin, that has been tachyphylaxis is less, and it is more effective and helps in tackling the feeding intolerance when compared to a single agent, either metoclopramide or erythromycin. Then other drugs, those have been tried, like serotonin agonist once, like a decade back or something like that. Sizapide, tigacerot, they were launched but withdrawn from the market because of the low safety profile. Many of the trials had shown in the infant patients with the cardiac arrhythmias. Then opiate receptor antagonist, we can have naloxone 8 mg QID when opiate are there, and more specific like mu receptor antagonist newly undergoing trials like alvimopan, it can be there. They are specific for the intestine, and they will not elevate the effect, analgesic effect of the opiate if that patient is on that opiate, and that will help in the motility of the gastrointestinal tract. Then CCK receptor antagonist, as we have seen the mechanism, increased level of the CCK are there. These are into the trials. Then some of the like ghrelin peptide agonist has been associated with increased mortality. Whatever trials are going on, it has been shown it may not come in the regular practice. And further studies for the newer agents or same agents and different strategies that may come there. Now these are the things we have seen, but we can, like, if we follow the feeding guidelines, uh, then we may prevent the occurring of the feeding intolerance. And which are the guidelines given by the ISPEN or European Society, or that we are like as a ISPEN member, we are following with the what to do in case of the vasopressurization. Start low dose enteral nutrition, hold enteral nutrition for patients who are being actively resuscitated. After resuscitation only, like, you will be starting, you can go for the low dose. Consider initiation or reinitiation of the enteral nutrition with caution in patient undergoing withdrawal of the vasopressor supports. And these recommendations are good practice point. All these recommendations, in this enteral feeding, they have been like evidence is based on the case studies or day-to-day practice experience. Major clinical trials like comparing the two sets, those could not be possible, or those have not been available still. But the whatever good practices we are following, that we have to go with that, so that we could prevent the things. We have already discussed, like where the feeding intolerance occurs and how to tackle that. Then second, how to achieve enteral access. If it is a short term, you can go with the nasogastric tube. If it is long term, go for the gastrostomy tube or jejunostomy tube. What recommendation? Infuse enteral nutrition lower in the gastrointestinal tract if patients who are at high risk of aspiration or with intolerance to gastric enteral nutrition. This is a moderate to high nutrition where chances of the aspiration is there. Use post pyloric feeding in patients with gastric feeding intolerance. Not solved with the prokinetic agents. How much energy? Accept below energy expenditure, like 70 initially. When you go with the energy, what calorie, nowadays many of the centers, they have the indirect calorimetry also. Whatever the patient requirement, caloric requirement is there, 70% energy expenditure, that can be you can start with, or even lower, that can you can go. Then gradually you can increase the energy requirement for the patient. Do not require specialized nutrition therapy over first week of the hospitalization in the ICU. That is the expert consensus. What recommendation in the ARDS or acute lung injuries that we manage? Like, you have to start early. Those expected to have duration of mechanical ventilation more than 72 hours, a good quality of evidence is there for this. Go with the again early nutrition, and that can be successful. If anyone is starting more than 72 hours, the already in that last chart we have seen that the p-value was highly significant, that feeding intolerance can be there, or we can have problem with the enteral feeding. When should energy dense formulas be used? Whenever the fluid restriction is needed, particularly in any critical patients. like fluid overload is there already, or we are dealing with the renal failure, we are dealing with the cardiac emergencies, then the high energy dense formulas you can go with. Then you are transitioning to oral nutrition, then at that time you can go for the high dense. There has not been any specific recommendation from ISPEN and European Society in this regard. How much proteins? As already we are practicing 0.8 gram per kg per day during the early phase, then it is increased to 1.2 gram per kg per day. Even in the situations like burn or multi-trauma, you can go with 2 gram per kg, or even 3 gram per kg. Those have been recommendation. And close monitoring of such patients, that is important. And again, the close monitoring for the development of the feeding intolerance, that matters. If at early moment you tackle, then that matters a lot. Various electrolyte imbalances you have to see daily. Whenever a highly critical patient is there, patient is chances of hypokalemia is there, or the hypokalemia worsens, you can go for daily investigation like potassium and those things. When should hyperprotein will be given, consider for the patient? Always when lean body mass calculations can be done with the biometric impedance technology. And when patient is stable, then you can go with the increasing the protein requirement for the patients, you can gradually increase that. Then monitoring of the renal functions is very important when you are going with the increasing protein feeding of your patient. How and when you start micronutrient supplementation? As thiamine is very important micronutrient, that may be important when you start, particularly when malnourished patients are there, oncology patients are there, or chronic alcoholic patients are there. These supplements matters. Even early start of thiamine, that has been recommend, you can go with that. Even high dose of thiamine you can give up to like 500, even 1000 milligram per day. And specialized requirement may not be needed, specialized nutrition therapy may not be needed at early stage, as per the recommendation or guidelines, or what we have practiced, we are seeing. And many other micronutrients like zinc, selenium, they have like as a cofactors at cellular level, very important things in the cellular, many cellular pathways that can lead to energy utilization. And that's why supplement of these micronutrients at appropriate time is very important. Then refeeding syndrome, that can be the challenge at the early stage, particularly in the as per the NICE guidelines. Like whenever the malnourished patients are there, particularly they are very much prone for such kind that thing. Plasma phosphate level monitoring, that matters a lot. You can have to monitor the plasma phosphate like once daily, or when really it is dropping, like when dropping phosphate is there, like more than like 0.16 millimole per liter, or you may need the monitoring like even 2 to 3 times, if like you are suspecting refeeding in some patients. Like as already I told, that importance of other electrolytes, that is very important. Potassium, magnesium phosphate monitoring, that is very strong consensus for that. And energy supply should be restricted for 48 hours such case, because these refeeding syndrome patients, if at all it goes, this is a very bad emergency one can encounter with. And such patients will definitely be they'll not going to tolerate the enteral nutrition, and very bad outcome would be there. So better at early stage, when you go with such patients, or when you are likely high risk for high risk patients who are likely to develop refeeding syndrome, uh, then at early stage analyze that part so that it doesn't develop, that matters a lot. Then this is a good to figure that is showing the same things, like you have to build the nutrition or energy over the initial days. Then meanwhile, like at 4 to 5 days, or around 1 week, you will be adding the other micronutrients, and you will be gradually increasing as per the condition of the patients. You will be it is always, if even low hypocaloric is always better, because these overfeeding problems really can lead to bad outcome of your patients, even if like you are supporting the other therapeutic to just tackle that critical ill patient. Then how to assess gastrointestinal and gastrointestinal tolerance. Already we see that regularly all everywhere in the ICUs we are practicing the gastric residual volume. The what is right now followed. Many of the times it happens that the every times like 2 hourly or 3 hourly your enteral feeding is planned, and the nursing staff that aspirate even like many of the time if we can see that 50 and 100 ml aspiration is there, and enteral feeding will be stopped for that low volume. Don't do that unless and until clinical symptoms and sign are there. uh, Otherwise even such patients can be if it is a low that way, or routinely like around 200 ml that we in our ICU also will be seeing that. But other clinical signs has to be there, like omitting whatever we discuss, abdominal distension, abdominal pain, and all these things, and dynamic ileus will be there. And like recent ISPEN guidelines, do not use, like in fact don't regularly use if you are not having the clinical signs for the feeding intolerance. Don't as a part of therapy, don't aspirate for every feeding. Do not use GRVs as a part of routine care monitor of ICU patients receiving the enteral nutrition. Finally, the many of the slides were the same, and the message from almost all the slides were the personalized nutrition is very important. That will help tackling the feeding intolerance early, or that will in fact prevent the feeding intolerance. Energy provision is guided by the indirect calorimetry, may improve outcomes, although gradually increasing the energy intake over the initial ICU days is essential to prevent the overfeeding. Lean body mass measured through bioelectrical impedance or ultrasound facilities when available in calculating the that you can go with the individual protein goals you can formulate the individual protein goals for those patients. Feeding intolerance is common and can often be, or it is like very well can be successfully treated, or when you suspect early, and various strategies you use appropriately. While there is no evidence of superiority of intermittent feeding over the continuous enteral feeding, post ICU nutrition that also matters a lot. Intake can be poor, particularly when the feeding tube is removed early. Uh, thank you very much.
Yes, thank you very much, Dr. Yogesh, for this wonderful session. Okay, so now may I request Dr. Sanjeev sir to give expert comments and initiate a discussion?
Yeah, fair enough. So, thank you, Padmaja. Now, I would probably take this discussion along with the experts that are there on this panel, and we'll try to come up with some conclusions in this aspect. So I welcome you all to this discussion now. And if anybody wants to have any questions, you please put it in the chat box. I think Dr. Jairam, Dr. Swapnil, Dr. Yogesh, and Madam Padmaja, we can actually have a good discussion on this. So the first thing I would like to ask, Swapnil is, Swapnil, how are you
Yes, sir.
actually defining feeding intolerance? How are you defining feeding intolerance in your ICU? I mean, when will you tell that this is intolerance?
Sir, we generally practice feeding intolerance in such a way that basically these are intensive care unit, that is a ICU patient. So common issue is that it can complicate the nutritional management of critically ill patient, and it is simply refers to patient's inability to tolerate enteral nutrition, which is characterized by symptoms that dictate GI dysfunction. That's it. So whenever we are having such symptoms, so which we have already discussed, so causes we have to find out basically. So causes could be critical illness or medications or hemodynamic instability or electrolyte imbalance and mechanical ventilation. So that is only my take, that whenever there are symptoms pertaining to the intolerance to enteral nutrition, which can complicate the GI dysfunction in terms of nutrition or ill patients, or the outcome that we generally define and take into consideration the feeding intolerance.
So this means to say,
That
what you're saying is that if a patient has 2 episodes of vomiting, you would probably call it as feed intolerance. How is that number there? Is there a number on vomiting? Is there a number on diarrhea? Is there a number on abdominal distension? Is there something that you would say, okay, this is because, see, very often there are so many other reasons for a person to have diarrhea. There is so many other reasons for a person to have vomiting. So is there a specific number or a specific value or a specific condition where you would say, okay, this is feed intolerance? Because what we're looking at is if patient is feed intolerant to feed, you may decide to stop the feeding. Okay,
Yes, sir.
once you decide to stop the feeding, we are related to a condition where the patient may get malnourished because of the fact that he's already low on his intake. So that
True.
way, is there a number? Because it's a very important thing. If we tell all those people who are attending this audio, this webinar, to say that if there is 2 episodes of vomiting, you must stop the feed, it will become a completely different thing that people will do. Dietitians may just
Absolutely.
stop the feed the moment there is vomiting. So how do you say that, okay, this is actually feeding intolerance? Or do you have a method by saying, okay, he has vomited, we'll give Amistat, we'll watch for a couple of times and we'll see how she's doing, and then something like that? Or is it the moment they get vomiting, you stop the feed? What is it?
No, sir. Generally, but there is no particular number of vomiting that we should stop the feed. But yeah, importance of MSET or any antiemetic medicine. Yeah, definitely we take use of those drugs, and definitely whenever it is necessary, we take help of those metoclopramide. I mean to say, some gastric motility drugs. So it can help in gastric emptying. So definitely
Right.
there is no particular number of number of vomitings or number of diarrhea. It is just a clinical judgment that whether the symptoms or the symptoms including vomiting or diarrhea are getting under control or not. So whenever these symptoms are not under control with whatever intervention we are doing in terms of any small medicine or just a change in position or change in diet, then definitely we can take a call on whether we should stop the feed or not.
So
But
what Dr.
generally, sir,
Swapnil, yeah,
yeah.
what Dr. Swapnil says is very clear, that only if there are intractable symptoms, he would decide to stop the feeding, is what he says, if there is intractable symptoms. So, Madam Joshi, in your dietetic practice, if you have a patient in the hospital, and let's take the example of a patient who is critically ill but orally feeding. Okay, we are taking an example who's
Okay.
critically ill but orally feeding. Now, he doesn't have a Ryle's tube. This patient does not have a Ryle's tube, and we can't really monitor anything there. So, this patient has got vomiting and now he's in front of you. Now, the important point that we have to make over here is this patient is vomiting. But madam, if you visit this patient in the intensive care unit, would you decide to stop the feeds, or would you try something else, or you change the feed? What would you do in this case? But I'll give you the clinical scenario. Patient has been there. Patient is a known case of diabetes, an elderly person who basically was
Okay.
admitted for, say, a trauma, and
Okay.
then patient develops vomiting. Now, what would you do here? Would you directly change the feed, stop the feed, discuss with physician, where what exactly are you going to do here?
Sir, the patient is on tube feeding. Sorry, I
No,
couldn't
patient is
understand.
orally fed.
Orally fed. Okay, okay. And patient has encountered vomiting, right?
Encountered
Just
vomiting, 2 episodes of
2
vomiting.
episodes. So first of all, we'll get into touch with the intensivist and the team of the doctors and find out the root cause. What could be the cause for the vomiting? Okay, and if with the help of the doctors and nurses, if we are able to control those episodes or vomiting or gradually reduce it, then we will take a call to feed the patient in a very minimal volume and then gradually increase the diet like that.
Okay. All right. So you basically would say that I would hold it, treat the cause, let it improve, then start the diet.
Yes,
Isn't it?
absolutely.
Yogesh,
with
what is
very
your
low,
practice?
with very low dose, with
With very low doses.
and
But
gradually increasing as per the tolerance of the
so when you
patient.
say low dose, what are you actually giving? What are you actually giving this patient in low dose? I mean, what are you giving?
So
What do you
far
do?
as
Do you change
liquids
the
are
diet?
yeah, so far as liquids are concerned, we can start very little, like 25 ml to start with, maybe 2 hourly, and then gradually increase. And once the liquids are tolerated, then gradually switch over to the semi-solid or solid, because the patient is elderly, he may be having problems for chewing and swallowing. So all those factors will be taken care while designing the diet of the patient.
Right. So what I understand is, in a regular oral care patient, it's, this patient is essentially not so ill, is what it appears. That's why orally
Absolutely.
patient is eating. So
Yeah.
waiting for a couple of hours and seeing whether he improves or not may be a
Yeah.
better bet than actually
Yeah.
trying to feed him actively. Now
Yes.
let's cut across to a patient who is and Yogesh, this question is to you. Okay. So if this let's cut across to a patient who is who is critically ill, okay, and the patient is on supports, but the supports are kind of stable. Patient is at 2 of say 4 or 5 ml of certain noradrenaline and vasopressin, and the question is open to Swapnil, Jairam, even you, okay. So if this patient comes in with a Ryle's tube in place, and now you have diagnosed this patient to be feeding intolerant. Okay, that means to say no. So in a patient with Ryle's tube, is there any other different way that you'll do? Now, Swapnil said that he would look at vomiting or distension or diarrhea. This is what he looked at, intractable symptoms. But in the patient who has a Ryle's tube, will your definition change? And I'm asking you this question because of the fact that, as you rightly said, the definition is not very well known. And the definition that you alluded to in the ISPEN guidelines is probably in 2012. It's been very long after that since we are into this spectrum almost 12 years now. So would you make a slight differentiation in a patient who's in critically ill with a Ryle's tube with respect to the definition of feeding intolerance?
Many, rather than a single symptom or sign, or what we can clinically find, if multiple things are developing simultaneously, like vomiting is there, distension of abdomen is there, that is a gradual process. It is like over one, it is not going to develop as on a certain. It will be developing like over 1 day or 2 day, and that intense monitoring, if it is there already, that would not happen. Or if at all it is happening, you have to tackle with those electrolytes and all those things. That paralytic ileus, like bowel sound, clinically listening, that is very important. And if it is really distension is there, and paralytic is frank paralytic ileus is there, bowel sounds are absolutely absurd, and patient has not passed the stool also, or say for the last 2 days or something like that. So that can be a grievous situation where definitely I would stop the feeding, and then definitely I may consider such patient to take on the parenteral nutrition. Or if like patient has passed the stool, if a bit clinical scenario changes and just vomiting is there, distension is there, potassium is in control, then we may go for the low dose enteral feeding, or we can space out the enteral feeding. And next day, again next day, next 12 hours, next 6 hours, and along with that, you can have the objective evidence of the gastric aspiration or gastric residual volume. If it is significantly high, then definitely you may hold that feed like for 12 hours, or you may hold that feed for 24 hours, something like that, and judge the clinic next scenario clinically. That matters a lot. But clinical signs and symptoms, they have to be correlated simultaneously. 3 to 4 signs not passing the stool, that is very important, and then according to that you go for your patients. That will be very important.
Yeah, so Yogesh put such a very, very important point in place that, and both Swapnil and Yogesh have, and Padma madam, you've put a very, very important point. The important point is there is not a single definition for feeding intolerance in the first place, and it has to be a combination. It has to be a combination of signs as well as symptoms. So the sign that Yogesh has alluded to is the fact that though we say don't measure, don't measure gastric residual volumes, the measurement of gastric residual volumes on its own does not make a difference. So if you do a gastric residual volume, in addition to other signs of gastrointestinal symptoms, then that combination is a very strong combination to predict feeding intolerance. So gastric residual volume on its own is of no use. And for all those who are attending this webinar, it's important for us to understand that the size of your stomach is the size of a fist. It is only as big as your fist. And it can actually go 75 times of this fist. This means to say your stomach can go from as low as 50 ml to as high as 4 liters. So your stomach capacity is very, very large. Unfortunately, the gastric residual volumes have never been proven to explain to us whether there is going to be a risk of aspiration or intolerance for that matter. There have been numerous conferences, and that is the reason that GRV on its own does not make sense. A combination of GRV, however, with a symptom of gastrointestinal intolerance, which is intractable, would probably be keeping us feed. So as Swapnil said, intractable, as Yogesh said, combination, this combination together will be intolerance. So have you noticed the prime cases? What are the prime 2-3 patients in which you would think that Jairam, if you would ask this question to you, which are those prime 2-3 cases? You can label 3 cases where you would feel that these patients would probably be in certain conditions where this patient would probably be intolerant.
So, especially for the surgical patients, we have the gastric intolerance, as we start with the liquid diet only to them. And if they develop gastric distension and have profound vomiting and have large bouts of vomiting, but we have to think about obstruction along with the intolerance to the feed. That is also important. And if the GRV is very high, then we have to also think about the intolerance to the feed.
So, Jairam, let's say about surgical patients, any other groups, Swapnil, that you think that will probably be at a high risk for intolerance?
Sir, particularly patients on a ventilator for chronic thing. Other than that, burns patient. Other than
Burns.
that, sir, yes, sir. Other than that, wherever chronic, cancer patients or the hematological malignancies, particularly, they are always having these problems, sir. But whenever we tackle such patients and we are going to label or before labeling only, we always have, sir, ultrasound, bedside ultrasound, which always shows some gastric volume assessment, and it is a best non-invasive tool for assessment of this gastric volume. I mean, particularly residual volume. Other than that, sir, bowel motility can also be visualized if ultrasound is better and person is quite expert in it. Other than that, sir, rate of gastric emptying can also be assessed with the ultrasound. So with that thing, this particular group of patients, sir, we can always detect in little bit earlier phase and can have a better action. Particularly in these malignant patients or cancer patients and these chronic ventilator patient and definitely, if possible, in burn patient also, sir.
Fantastic.
Also the diabetic patient who have diabetic gastropathy, they are more prone for the intolerance.
And
So,
of
so,
course,
so Jairam, Jairam,
patients with
yes,
refeeding
yes,
syndrome
Abhishek.
also. Yeah,
Refeeding syndrome, yeah.
yeah.
So, I'd like to make a small correction on this, Dr. Jairam, and I mean, let me just correct this a little bit, okay? With your permission, let me just correct a few things
Yes,
here.
yes.
So, Swapnil, you
Yes,
were
sir.
absolutely spot on by saying that burns patients, and Jairam, you were absolutely right in saying surgical patients. So there are two group of patients where there is going to be surgery because of the inflammation that the surgery renders will actually cause gastroparesis and lower intestinal motility.
Yes,
Whereas burns per se, also because of the extreme inflammation that occurs with burns, there
yes,
is going to be a similar response that is occurring in these cases. Another category that you said, oncology, yes, that is also absolutely fine because every hormone is deficient when it comes to cancer. And the fourth very important group is two important groups. One is the polytrauma patient and the head injured patient. So the head injured patient and the polytrauma patients are other two groups which will actually have very poor gastric motility, and we will be very careful when we feeding polytrauma
yes,
patients as well as head injury patients, because again it looks like sympathetic activity being over hypersympathetic, which is actually causing gastric motility to come down. But when it comes to diabetes, there is one trivia. Diabetes does not cause an increase in gastric residual volumes. It doesn't do that. It doesn't do that at all, because what happens in this case is that gastroparesis does not occur when you have diabetes. This is a very important thing you must remember. It is pseudo normalization that occurs when it comes to gastric. Okay, pseudo normalization. This means to say the fundic relaxation and the propulsive movements become actually normalized when you have diabetic. When you're diabetic, this is what occurs. And this is very, very interesting. So that's why if you see, we are working in a diabetic hospital, we don't see so much of gastroparesis. We see no gastric volume coming changing. This is because diabetes patients, for some reason, it's called a pseudo normalization. It's a known term which actually causes the fundus to relax so beautifully and propel so well that it actually improves the gastric output. This is what occurs in diabetic patients. That's a trivia that's very important here. So Yogesh, so this Swapnil did talk about the fact that he would do certain interventions to diagnose it. Would you suggest certain interventions to negotiate the Riles tube, or what would you do, for example, if you have the Riles tube having a residual volume of 500? Would you consider any other form of tube in these cases, or you would just
Sir,
leave it that way?
I will
yes,
definitely try to put one Preca tube, particularly post pyloric area or just below fundic or somewhere else. So if there is any particular and I will have this Preca or GI tube for continuous aspiration. If there is any abnormality or large collection, in spite of being on medicine of prokinetic medicine, still then, and after the assessment of this USG or indirect calorimetry or immunonutrition, in that case, then only I will think of other intervention. I mean to say other intervention in terms of if there is any gastric or gut ischemia happening, or any immunomarker, any markers I have to do, like citrulline or something like that. That we generally don't do, but yeah, we have to consider. Other than that, if there is any immunomodulation which is doing all these things, by having this Preca tube, other than this Riles tube, or there is any edema of intestine or any part of gut, or that thing I will take into consideration. Other than that, if there is definitely these electrolytes and all these things are any cause, then definitely I will correct it. That's all, sir. Other
So
than
what
enteric,
I understand from Swapnil is the fact
yes, sir.
that if there is Riles tube feeding and it's intolerant, he would go to post pyloric feeding so that the we can negotiate the intolerance. Yogesh, do you want to differ in this by any chance, or do you want to agree with Swapnil?
Yeah. I agree with Dr. Swapnil. The main thing, like it can gastric intolerance that like we encounter regularly in the ICU. That is, I'll just label like mild to moderate grade of severity, and that can be easily successfully managed when you tackle the underlying pathology. That shall be the first approach. And other measures like intervention measures, these are less likely to required, like either jejunostomy, and many of the conditions like severe sepsis, like severe hypotension, septic shock is severe or something like that, mechanical ventilation, patient is on mechanical ventilation. In such situation, like even like bowel ischemia is significant, or gangrene, like, or any intestinal obstruction you are suspecting such a pathology, if it is that way, then definitely in that scenario you would not be, even with other intervention, you would not be able to entirely feed that patients. Then definitely you will have to take care with the parenteral nutrition in such patients, and that clinical judgment has to be there. But yeah, easily that it will be successfully managed with the underlying hypokalemia is corrected, hypomagnesemia is corrected, then prokinetic medications you are done with, or just you have started with the low dose of the enteral feed. In the common feeding intolerance, what we see in the mild grades of intolerances, we see actually there is no grading or something like that. Usually aspirations can be there, like 200 or something like that, just resting for some time. And it can be the multiple polytherapy that has led to severe gastritis, that has led to the vomiting and few combined symptoms. So easily that can be tackled successfully, like feeding intolerance. And other resorts are last resorts, but they may not be needed if the such severely ill patient is there, and even that those will not help in those cases, then definitely parental nutrition will be the resort.
So what I understand from here is that nobody would directly go from a Riles tube to a post pyloric tube. All of us sitting over here, if there is a Riles tube in place, we would probably first try all methods that it will take to actually feed the gut through the Riles tube itself, through the nasogastric tube, before going to a post pyloric access, because we know evidence says that the post pyloric access is actually equivalent to pharmacological measures. So this is what we know, that the post pyloric tube is equal to the to the pharmacological methods, and that is the reason you will first try with the pharmacological measures, which includes the two drugs, metoclopramide and erythromycin. And for all people sitting over here, it's very important to know that this drug needs to be dosed properly. We can't just give 10 milligram and stop at it. We can't give erythromycin 10 to 250 milligram and stop at it. It has to be done QID. It cannot be stopped, because the problem is that it develops a tachyphylaxis. So it's important to do it quickly. Either you do it quickly or don't do it at all, because you either give it three times in a day for the next 2 or 3 days so that it starts properly, or don't do it at all, because one dose is not going to help. So, Madam Joshi, is there
Yes.
as a clinical nutritionist, when
Yes.
you see such patients with
Yes.
feeding intolerance, do you go and suggest, because very often doctors are very
Yeah.
busy,
Yes.
looking at
Yes. Yes.
looking at all these
Right.
other parameters like
Right.
hemodynamics and all these things, very very busy looking at all those things. So
So
when you are actually seeing that this patient is having gastric residuals, or you're seeing that this patient is having vomiting or things like that, do you go and suggest the activity to start pharmacological measures? Do you suggest them, or you just say you don't be a part of the entire team there? What do you do?
no, if the patient has intolerance and diarrhea, I would First of all, rectify other things like switching over to the lactose free, then speaking to the doctor, is that any medication which is any antibiotic which is causing the diarrhea, all that. And if still it is not been resolved, then we may switch over to the peptide based formula. That is
No,
what.
Madam Joshi, I'm asking you, how comfortable are you to go and tell the doctor that, sir, please start pentachlorpromide and erythromycin? That is the question I'm asking you, because this is something that will help. We know this will help. So if this is going to help, will you go and tell the doctor, or you will wait for the doctor to do it himself?
I will tell the doctor.
Absolutely.
That,
So this is what I
yeah,
wanted to hear. So
yeah.
one of the things that has helped feeding intolerance is the making a nutrition support team. The nutrition support team, which actually has the dietitian, the doctor, the physician, the pharmacotherapist, all of them together, will actually help in actually getting this through quickly. Very often, Dr. Yogesh, Jairam, and Swapnil, you'll agree with me that intolerance occurs and we don't know only what has happened. After 5 or 6 hours, next day afternoon or next day in the morning, they say, "Arey, patient had vomited yesterday." It's very simple for the nurse to say there was too much of gastric acid, I stop the feeds.
Yeah,
The
yeah.
register. So this is
Very
what
common
happens.
practice.
So
Very
so
common
th-
practice.
so when
Yeah.
you have a nutrition support team, having a
Sir,
dietitian and a
sir, we are
pharmacist.
very approachable in that case, and we are very approachable by dietitians too.
Yeah,
So
yeah.
we
So
Great,
can
the
great,
answer
definitely.
is,
sir. Great,
so we should
great.
have a nutrition support team which actually does
Yes,
this
yes,
trick.
yes.
And for all members sitting in this audience, it's important for us to understand that the post-pyloric tube actually works quite well because of the fact that for all practical purposes, the intestinal motility still remains, though the gastric motility has gone down. So that's why the post-pyloric tube actually works much better. And for erythromycin, it is actually the motilin receptors, which is the phase 3 phase of feeding. So you have 3 phases: the quiescence phase, and then you will have the irregular contraction phase, and then you will have the activity phase. And the activity phase, which is the phase 3, is where motilin receptors are known to work in such cases. What is your experience with opioid, Jairam? Do you see we put patients on opioids, we put them on fentanyl, we put them on high dose fentanyls. Do you think that this reduces gastric motility? And what do you do in such cases if, say, for example, you have no other reason for reduction of gastric motility and you are just on fentanyl at, say, 150 microgram an hour? Do you notice this happening regularly in your private practice, in the hospital?
It is not happening regularly, but in some patient, when we give the fentanyl for the pain control, or especially for the post-surgical patient, they develop the gastric intolerance, and for that we need to switch over from the fentanyl to the epidural. We generally use the epidural for controlling the pain for the major surgeries, and otherwise we have to use the non-opioid based analgesics for controlling the pain in such patients.
So what he says is opioid. It's very common to have opioids, and it's common in intensive care. I mean, it may not be common in outside the intensive care, but at least in intensive care, when you give opioids at the doses that we give, there is going to be an intolerance. Are you also having the same practice, Yogesh and Swapnil? Do you see the same thing, Yogesh?
Yes, regularly it will not be there, and the set of practicals like in the practice where the fentanyl is maximally used, they may be dealing with the severe cases of the feeding intolerance, but it is not that common per se. Like regularly we'll be seeing just because of the fentanyl, the gastric motility has been hampered, and we have to use the prokinetic or something. Again, the whatever primary, even other causes we have to find out, and they will be there, and we have to go from ABCD, and we have to treat the primary causes, and along with that, whether it is because of the fentanyl itself, that will be acting that way.
Okay,
Sir, particularly about this opioid, whenever we are using in post-op phase, then we will not find out, we will not get those much cases. But whenever we are having patients having chronic use of fentanyl or fentanyl patch or some opioids, then definitely, sir, these incidences are there, and we have to stop that opioid for a little bit sometime, and we have to take care of analgesia part with other things, and then again we have to restart if there is any need. Definitely, sir, in
absolutely.
chronic
So.
patients, wherever patch is
um,
there, we are facing these things.
Absolutely. So this problem is normally faced in oncology, where patients are on very high doses of morphine and fentanyl, and as Madam Padma Joshi said, that cancer itself drops the appetite, and at the same time, makes it very difficult to actually tolerate feed. So there is a problem with respect to oncology and opioids and gastric residual volumes and feeding intolerance for certain. Well, has anyone in this group used naloxone to combat opioid intolerance?
No, sir.
No.
No.
So let me give you an example of how we used to do it abroad, because of the fact that we did have naloxone abroad with opioid intolerance. It's extremely cumbersome. It's very easy to say use naloxone, but it's extremely cumbersome. And I'll explain to you why. Because the dose for naloxone in such cases is 8 milligrams, and what's available is 25 microgram. So you're supposed to give 20 ampules. You're looking at of naloxone inside. That's how it works. 8 milligrams. That's how it is, and you get a very small amount in ampules. So that's why the dose becomes 20 ampules you have to break. 80 milligrams comes in 80 micrograms. So your 20 ampules is what you have to burst when you are actually using it for opioid intolerance. It's a problem, yeah. Madam Padma Joshi, when we are actually putting a post pyloric tube,
Yes.
what is your practice? Do they start immediately after feeding when they are actually starting post pyloric feeding, or you wait for some time and then you start? What have you seen when you look at post pyloric feeding?
Sir, wait for not very long time, but little time we will wait, and then we will start with in the patient who had a very high degree of intolerance, and that is why I put the post pyloric feeding tube. In this patient, we will start with a diluted peptide based semi elemental formula. Okay, maybe half diluted, gradually progressing to the full strength, and then gradually progressing to the kitchen based diet or formula diets, like that.
So it does appear that if you were to start on, we know for certain that if you put in a post pyloric tube and the motility is preserved, it is good to start it as quickly as possible, because there is
Yeah.
no
Yeah.
reason to stop the feed, because we are
Yes,
understanding that
yes,
motility is going to be kind of persistent in these
yes.
cases. Importantly, for all listeners sitting over here, it's important to know that you really don't look at gastric residual volumes anymore, because this is post pyloric. Once this is post pyloric, there is no GRV. There is no reason to aspirate this. And that is the reason that aspiration is not supposed to be done once you're in pyloric post-pyloric tube, because of also the fact that the post-pyloric tube is a very long and a thin tube, which has a very high tendency to get blocked. So it's important that we don't aspirate, and write it on the paper that you do not aspirate such tubes at all. Yeah. So, do you do any positional alterations, Yogesh, if by any chance there is going to be feeding intolerance? Do you say, for example, you have a patient in your supine position, and this patient is having feeding intolerance? I mean to say, there is large gastric residuals. Let's take it as 500 ml gastric residuals, and there is a abdominal distension. Would you consider changing the position in such patients when you are on having feeding intolerance?
Like if patient is not much more unstable, then 30 to 45 degrees that we can keep. How much time, there is no defined time frame, but many of the time in the what practices like routinely and we are doing for the feeding, we give that feeding in the 30 to 45 degree of the things regularly to prevent itself, or that position if it is feasible, then you can put in that position. That would
Right.
help, and again reducing the volume of the dose of the enteral feed, that will be helpful in managing that feeding intolerance.
Right.
That clinically that
So,
you can
yeah,
go
yeah,
ahead with.
perfect. So Swapnil
Yes, sir.
and Jairam, is there any way that you think that a lateral position might help in such cases? Swapnil.
Sir, it will be very much individualized thing. It is not necessary that it will be laterally or right lateral, left lateral, or supine, or sometimes in a ARDS patient, a patient is in prone position. So it is very difficult to say, sir. It is obviously individualized. But sir, there are lots of benefits in post pyloric feeding, particularly in patients who have risk of aspirations, or GRD reflexes, or there is some pancreatitis patient, chronic pancreatitis. Whenever we want to maintain the gut integrity, in that patients, definitely we have to use it. But yeah, whenever we are dealing with the position, particular position we are having, that it should be individualized. That's what we do, sir, over here.
Right, right. So there are a few
Sir, in
questions that
propped
have
up
come.
position,
Jairam, you?
basically in the propped up position, the feed is tolerated better than the other positions.
Yeah, there's recent data that actually talks about the right lateral position, which would probably help in such cases. That's the reason that I put up this question, because the recent data that says for the right lateral position, you can actually move the food from through the pylorus is what it says.
But matter would be that how long you will be keeping in that
Yeah,
lateral position,
yeah,
and
yeah,
everything that will have to
yeah.
be.
So that's something that is there. So there are a few questions that have come in the chat box, and one of the question is, shall vulnerable patient be treated in the same way? No, acho, Yogesh, okay, let's ask this to Yogesh itself. Yogesh, what do you feel? Vulnerable patient treated the same way or anything different?
Already all the unstable patients and all the guidelines we discussed already, I guess.
So no,
In,
okay, okay,
yeah.
right. So, I think we've had a very fruitful discussion, and I think we've gone through a lot of points. I mean, this discussion can just go on and go on and go on because there's so much more that we can discuss when it comes to ultrasound, when it comes to ECG guided feeding tubes, the Tiger tubes, the Gestar tubes, and different kinds of methods to co-track method to actually put the post-pyloric tubes. When you look at advances, there are so much drugs that are coming in place, including the growth hormone ghrelin, along with things like CCK and YY peptide. These are fantastic drugs that are coming in. Of course, there were earlier drugs that Dr. Yogesh talked about, tegaserod being out of the entire circulation, F5-HT4 inhibitors, which basically helped in such cases. However, I'm certain that very soon we will get more drugs which will probably work in this aspect. I think so. I think we've had a very good discussion in the last 1 hour or so. Jeremiah, over to you for the next part of the entire webinar.
Sir, before that, I want to
Thank-
ask you one question.
Yes, please. Yes.
That there are some emerging researches and trends going on. So definitely gut lung axis is, but we are already working on it. We are already understand the thing. But thing is that role of microbiome targeted therapies, what we call that FMT, that is fecal microbiota transplantation, is. Can you please enlighten sir a bit on that
Yeah, so
thing?
everything in the gut is the microbiome. Everything in the gut is the microbiome. In fact, if there is an intolerance, there is a very high chance the microbiome is gone. And if you ask me, what Padmaja said is the most important part, I feel. The thing that causes absolute disruption of the microbiome is actually the antibiotic. Okay, so getting down on the antibiotics would be the best thing that you can do if there is feeding intolerance, if it is possible to get down the antibiotics. But in the presence of an antibiotic, we really don't know what is the quantity of the probiotic or what is the quantity of the microbiota that we have to add. The dose is not very clear, but yes, there is huge amount of data that is looking at microbiota, fecal microbiota transplantation and microbiota in reimplantation into the gut to actually improve tolerance to feeding per se. There is emerging evidence that also looks at microbiota altering the motilin receptors, microbiota that is altering the cholecystokinin receptors in such a way that it actually improves the tolerance in feeding. There is great data that talks about diarrhea and fecal microbiota transference and transfer in such cases, especially when it comes to inflammatory disorders like Clostridium difficile colitis. So there's a huge amount of data that comes when it comes to vomiting and probiotic, but we still are not very certain whether what is the bacteria, what is the microbiome, and what is the dose that is required on the microbiome. Though we see great improvements. Our grandmothers have told us that if you have a lot of vomiting or diarrhea, have curds. I mean, that makes such a big difference when it comes to this condition. So and I think we still have to learn quite a bit when it comes to microbiota, but we are gaining there. I mean, I think the next webinar that ISPEN Mumbai conducts, maybe after a year or so, we would probably talking this is the microbiome that we require to get around intolerance, and I think we're not far away from that answer, I feel.
That's it, sir.
Yeah, Jairam.
So before ending our webinar, I would like to invite Dr. Abhijit Deshmukh from Pune ISPEN branch. He is the in charge of neurointensive care unit at Ruby Hall Clinic and immediate past chairman of ISCCM Pune branch. He is also treasurer of SNCC from 2024 to 2026. He will tell us about the upcoming ISPEN Pune National Conference. Over to you, Dr. Abhijit Deshmukh, sir. I am sharing one screen of ISPEN Pune conference.
Right. Thank you, Dr. Jairam, and thank you, Dr. Sanjeev. I'm extremely sorry I have joined late because of the uh, schedule and the ongoing busy which is going on in the ICU. But what I understood and the last 10 minutes which I was able to listen to your discussion, it's an excellent discussion. All the practical points you were discussing. And to continue with these fruitful discussions, I would like to invite you all to Pune for the ISPEN 2024, which is going to be held under the leadership of Dr. Sanjeev as a president. So I hope you all will come there and will have the Pune Culture Academic program enjoyment here. And thanks a lot.
Yeah, Abhijit, we will definitely be there, and all of us would be there, definitely for certain.
You have to be there, Sanjit. You are a president. But for the attendees and Dr. Yogesh, Dr. Swapnil,
Yeah, definitely. Already you were not there. Dr. Sanjay told that they are coming by, the whole family is coming by bus, the whole ISPEN Mumbai.
We will
So
come
probably we
together.
yes.
would also plan
We
that
all are
way.
going to come together, definitely.
So, Jairam, there is one question that has come in the chat box. Okay, and I think we can give this question to our expert speaker to answer that. I think we should answer that before we leave.
TPN.
Yogesh, the question is, how long
TPN.
can we use TPN considering the side effects? When you just said TPN for if the feeding intolerance is there. So, Yogesh, what is your take on this?
TPN till the I would just answer this, that TPN till the time patient is clinically stable or patient is needing that, and till the time you are able to start with the enteral feeding for such patients, that will be the time duration. Like as early as if it is possible for you to start with all parameters are stabilized, and you can start with the enteral feeding, then overlap the TPN, and along with that start the enteral feeding, and then you can consider of stopping the TPN. So that can be like 4 5 days also, that can be like 15 days also you may need. But when the patient is getting stabilized, patient is coming out of the critical illness, when you are winning up from the ventilator, you are like coming out of the shock or that way, then definitely then gradually that you will be stopping the TPN. And in our case, I would say that one of the case, like 10 to 15 days, right hemicolectomy was done, and already that patient was for like more than 15 days he was in the other hospital, and that completely in the malnourished case he presented, that colostomy was done, and that patient we kept around like 10 to 15 days of TPN, and after that gradually we took that patient on the enteral feeding, and we could stop that, and after like weaning from ventilator and all those things, like 1 to 1.5 months that took for that patient. And that is a gradual process, and that is the way. It's not there is no defined time like after 5 days you will be stopping, after 10 days you will be stopping. It will be the clinical judgment that will be the important, and stabilizing and winning from all other reasons for which you have been starting the TPN.
So I'll also answer this question if it's all. Jairam, can I just take this question also?
Yes.
Yeah. So you do have TP, and how long? If somebody asks how long you can do it lifelong. I mean, there's nothing. You can do it lifelong. You have so many patients of short gut syndrome that are there in the country which don't have access enterally. They can't take enteral nutrition at all. There are multiple patients that way who have got short gut syndrome who are living with home PN, isn't it? There are so many of them living with home PN. As long as it is done well, monitored well, looked at very properly, the home PN can be continued for life. There is nothing like that on not having it. You have to monitor it. You have to monitor for all the required side effects that are there and accordingly make your judgment. But the question here should not be TP and how long. And as rightly Yogesh said, how quickly are we going to stop it in the case of critically ill patient? That is how it is going to be. So it's not how long I'm going to continue it, how quickly I'm going to stop it. It should be the question over here. So we have to stop it as quickly as possible. The moment we start trophic feeding in critically ill patient is the answer to the question. And if it's in general public, it can be done even lifelong per se. Okay, over to you, Jaram.
So I would like to thank you, Dr. Abhijit sir. Uh, he has given us time on very short notice. I have just yesterday contacted him, and he presented to us, and he has introduced and he has told about the ISPEN Pune conference, and we will be very happy to come for the Pune National Conference, and we will be come in bus only, as Sanjit sir said.
I would be
So,
very happy to receive you on that.
okay, thank you. I would also like to thank you, Yogesh sir, for such an excellent presentation and very informative session. I would also like to thank you, Padmaja Joshi madam, for moderating this session. I would also like to thank Dr. Swapnil and Dr. Sanjit sir for being an expert panelist for this session. I would like to thank you, ISPEN and Sanjit sir, for allowing ISPEN Mumbai branch for conducting this webinar without any sponsorship, and we have not given any charges for the ISPEN logo in this at this time.
Great.
So
Great.
many more webinars of the ISPEN Mumbai branch will be in the line, and next webinar will be held on 23rd of this October which will be on the nutrition in the liver diseases, and within next 1 week we will have the nutrition in the burn diseases. So
Great.
link for the next webinar will be shared shortly. And with this, we are ending this session. Thank you all the participants for attending this session till the end, and thank you.
Thank
Bye-bye.
you.
Thank you.
Bye.
Thank you very much.
Thank
Thank
you.
you
Thank
very
you
much.
very much. Thank you very much.
Thank you very much.